Good afternoon, or actually good evening, class. We're going to spend a few minutes. Last session, we kind of backtrack a little. Last session, we talked about um, payers' utilization of data repositories, the importance, how providers use that information that they extracted from a data repository, different reports that they could generate, the financial operational impact on the payer's organization. Um, and so as I even said last time, decided on the information warehouse and data repositories because, again, we're talking about uh, two sides of that financial coin. And anytime you're talking about two sides of the financial coin in a class, I try to provide some prospectus regarding both sides of that financial coin. So last week we talked about payers. This week we're going to talk about the provider side of that financial coin and what they do with data warehousing. One thing that you'll probably notice as we go through this, there'll be several of the concepts that we're going to talk about on the provider side that actually you probably remember when we talked on the payer side. The information I provided last time with respect to payers, I've taken from various sources out on the internet, and similar thing or similar approach with the providers side of the house. I've taken information from several different sources that I found out on the internet and tried to compile a PowerPoint that I floated out there for you. But just you'll see, I think, as we kind of go through it, that there are a lot of similarities. So there'll be some differences, but there'll be a lot of similarities, especially on the importance of information and the importance of being able to develop a team that is skillful in extracting that data, turning it into actionable information that can be used on the provider side of the house. Because again, remember, providers are in the business of providing healthcare goods and services to drive revenue streams. They're driving profits, and it's based on their efficiency, their ability, the perception of their quality, of the activities that they provide to that consuming population with respect to healthcare goods and services that's going to actually drive their ability to be profitable in the long run. Just quickly, let's go back to the payer side and remember the payers. If you think about the payer, and then when I say payer, I typically think about a health plan. But when you're thinking about a payer or a health plan, they are really acting as a facilitator. They're acting as a clearinghouse to ensure that buyers and sellers of healthcare goods and services adhere to the contracts. When you think about sellers of healthcare goods and services, you're going to be thinking about the provider side of the house. When you're thinking about buyers of healthcare goods and services, you may be thinking about government agencies. You may be thinking about state and local agencies. Maybe thinking about employer groups, maybe thinking about individual consumers, and like small business or individual selection of healthcare goods and services or individual selection of contracts. And while the employer group negotiates a benefit package with the health plan for healthcare goods and services that they're going to purchase for their employees, each individual employee of that organization signs a contract that says, I understand the parameters of the contract, I understand the benefit package I'm going to get, I understand what my copay is going to be, my co-insurance, my deductible, and they sign a contract. And again, health plans are the facilitators and clearinghouses to ensure that on the buyers and the sellers that they're both adhering to the contracts. Think of, sometimes for students, it's especially financial students, it's easier for them to think of a health plan simply as the clearinghouse for the Chicago Board of Trade, the clearinghouse for the Mercantile Exchange, maybe the clearinghouse of New York Stock Exchange. That clearinghouse is bringing buyers and sellers of financial instruments or commodity-based instruments together and ensuring that they both adhere to the parameters that the buyer and seller agree to when they negotiate or initiate one of those contracts. One thing about when you're talking about the payer side, healthcare informatics professionals on the payer side, they are, for the most part, are trying to do a couple of things. They're trying to ensure that the claims adjudicate accurately. They're trying to determine are the healthcare goods and services appropriate for the episode of care that the individual has, or the covered member or the buyer has. And there's, for the most part, in a health plan, there is going to be minimal access to the enterprise data warehouse, as we talked before, the EDW, or the information warehouse, however you want to, whatever terminology you want to use. And so when we talk about minimal access, when we get into, you think about that on the payer side, when we get into the provider side, there is the probability or the possibility, let's say, that you're going to have more individuals with access to that information just because it's the nature of the beast on the provider side. And we'll kind of walk through it as we go through it. But hopefully that sets the stage on the provider side of the house. And now we're going to talk about the importance of healthcare data warehousing. And again, it's, if you want to define it, it's a key role in modern provider environment. It's not just a useful tool, but a critical necessity. I can remember when I started in the healthcare environment, I went to work for Aetna in early 1990s. There was a lot of analytical work taking place on the health plan side or on the payer side of the house. But when I talked to individuals that I knew that were working on the provider side of that financial coin, either in a medical group or a hospital, there wasn't a lot of analytical work going on at that point. There was a lot of, I'm going to say anecdotal, but a lot of their decision-making processes were not necessarily driven by a significant level of understanding of the data that drove healthcare goods and services. And it's changed over time. And, if you think about it, at least when I even think about when I, was growing up, there were a lot of sole proprietors, few partnerships when it came to non-hospital type providers. So the primary care doc that I went to, he was a sole provider, sole proprietor. He was, he was there. His wife was a nurse. His wife was his nurse. He had an office. I grew up in a small farming community. He had an office there in town, and he could walk out the back door of his office, and there was the house he lived in. And on Saturdays or Sundays, if you needed something, you would go into, not to his office, but you would go into his house, and he had a little examination room set up on a screened-in back porch, and that's where he provided services on Saturday and Sunday if they were needed. Just a lot of, and I'll call them mom and pop type practices. And in the days of these mom and pop type practices, for the most part, are probably have gone by the wayside. Also, on the provider side of the house, the spreadsheet analytics, while there's still a few around, it has become more and more sophisticated over time. And that's why that first bullet on the PowerPoint slide talks about it's not just a useful tool, but it's a critical necessity to manage the operational and financial aspects of that provider organization. The provider organizations and the provider community, it's driven by information management of vast amounts of data. And as we'll get into it a little farther down through here, but the data that you're going to find in a provider's data warehouse can be, for the most part, significantly different than what you're going to find on the payer side of the house and information warehouse. And both the payer and the provider, so both sides of that financial coin, are working with vast amounts of data. And it is critical that either on the payer side or the provider side, that those organizations have the intellectual horsepower, the intellectual expertise to take and turn that data into actual information. On the provider side of the house, there are challenges with data governance, and data quality. I'm not sure that even in today's world that maybe on the provider side of the house, there are as many resources expended ensuring that data governance sits on top of that information warehouse. And as the providers try to ensure that the data quality exists in their warehouse. You've got, as we talked about in one of the earlier classes, one of the earlier modules, HIMS, HIMS, are the kind of, I guess it's the identifier, at least on the hospital side of the house, of healthcare, informatics type individuals that are in there doing the data mining. So, and one of the aspects of data quality is you have so many individuals kind of in the provider continuum that have access, and that not only access to the systems, but may be driving the information that goes into that information warehouse. Depth of healthcare talent pool and development of human capital. I can go back to my days at Blue Cross Blue Shield in Buffalo. Talent pool in Buffalo is a little shallow. There was a lot of competition for really good talent. Blue Cross Blue Shield was there. There was another Blues plan, had some unbranded business in Buffalo. Centene was in Buffalo. Some of your national players were in Buffalo. There were some regional health plans in Buffalo, had two huge hospital systems. Everybody in Buffalo that were functioning in the healthcare environment were in competition as they tried to secure the talent that was going to be required to ensure that the information had the quality and the accessibility that everybody needed on both sides of that financial coin. Competition was keen. I don't want to say the competition drove the price outside of the realm of possibility, but the price of healthcare talent, especially analytical talent in the Buffalo market, was probably a little pricier than you might see in some other markets. You talk about complexity of accessing, clinical operation financial data, and if I think about a health plan, as we talked about last time, you're mostly focused on paid claims data, provider data, enrollment data. Most of the big three. If you're talking about especially a multi-specialty provider group or a hospital system, you're not only concerned about operational data, and you're not only concerned about financial data, but you are concerned about how patient flow works, and how your resources are allocated, and what the wait times are in the office, and you're concerned about how many patients cancel on their visits. You're also concerned about helping providers access clinical information in such a way that it's going to allow them to minimize the issue of asymmetric information, to minimize any potential principal agent conflicts. And it is an extremely, to me, it's a more complicated task on the provider side to kind of get your arms around the information and parse it out in such a way that you can provide the relevant information that those providers are going to need on a daily basis. You have to, especially on the provider side, you have to adhere to security standards and unauthorized access. Again, there are a lot of individuals scattered across that entire provider continuum in healthcare that may have access to the systems, may have access not only to systems, but to the data that is stored in that information warehouse or that data repository. And there seems to be a lot more flux or a lot more transition. And again, it's anecdotal on my part, but if I just go into the doctor's office and look around, every time I go to my doctor's office, and I don't go that often, but when I do go, or when I take my wife to the doctor's office, it almost seems like it is while the doctors appear to stay the same, it looks like the office staff it's just a complete turnover. I don't recognize anybody from one office visit to the next. So always a little concerned about unauthorized access, always a little concerned about turnover, always a little concerned about what's going to happen to my private health information with that much turnover, especially to a certain extent, a small organization, because I think there's only 4 or 5 doctors in the practice that I use as my primary care doc. And then you've also got breadth of required association, state, federal, reporting requirements, sending information to the AHA, American Hospital Association, sending it to the AMA, American Medical Association. You've got states, you've got local, you've got federal. Provider side is constantly sending information to CMS, especially if they're accepting Medicare patients or accepting Medicaid patients. Just a significant amount of information required. And think about if you're a provider practice, and it doesn't have to be just a medical practice, but a hospital system, and you're trying to secure grants at the state or federal level. Think of all of the information that you have to concatenate and collate and put together in a reporting format to satisfy those grant requirements. Again, it's the amount of information that a provider, a payer has to provide a lot of information to government agencies, but it seems like to some extent providers may be expected, or the expectation may be that providers have to share a lot of information, or at least a significant amount of information with outside agencies. They're talking about staffing issues. They're talking about especially quality issues. Think about hospitals. They have to report hospital acquired conditions. So individual goes in for surgery, bring her out of the surgical suite. They're not paying attention. She rolls off the gurney and breaks her shoulder, breaks her arm, breaks her leg. Something happens in the hospital and the patient ends up with sepsis. Other types of issues that happen in a hospital setting. They're also, hospitals and providers are constantly providing financial information, operational information to a lot of these government agencies and a lot of these associations. So just a lot of information on the provider side that is being funneled to either state, local, federal agencies, or some type of medical association. And when we talk about on the provider side, this is somewhat repetitive, I guess you could say. But when they talk about a warehouse, a data warehouse on the provider side being defined, it's a comprehensive, centralized, accessible repository of various types of healthcare data. Sounds a whole lot like a payer definition of a data repository or a healthcare warehouse. And it is to some extent very similar, quite similar. They're both centralized, they're both comprehensive, and they both should be an accessible repository. I think about the last time I went in to see my primary care doc. He happened to be, kind of watching him while he's playing on his computer, typing information in, and he's using Epic. It's a electronic health record system that transfers information, and it goes as long as I stay in the hospital system, seeing you go to their hospitals, their emergency rooms, their urgent care, seeing their providers that are within that system, my information is going to be available to anybody that I go see as long as I stay within that system. And that is an advantage from the provider side because it does help them to have a more complete picture when they're trying to determine what issues or what treatment patterns they can offer me based on the issues that I'm currently having. When it comes to this comprehensive, data, you've got clinical data, you've got treatment plans, you've got episodes of care, you've got patient histories. A lot of the patient history is self-reported because it comes from information that the patient provides when they go in to see the doctor, when they check into the emergency room, or when they're admitted to the hospital. I mean, it's the same thing for most of us. We go into the doctor's office, and there's a whole sheet of questions they're asking you. Do you smoke? Do you vape? Do you drink? Are you depressed? When was the last time you had surgery? Have you had any surgery? I mean, just this whole litany of information. A lot of it's self-reported, but they're using that information from those patient histories, either to some extent ancient history and to more recent history, to develop treatment plans and to manage episodes of care that individuals have. You may have a patient that has congestive heart failure, diabetes, asthma, allergies. All of that information, if it's captured in that electronic health record, electronic medical record, and it's accessible to the provider that you happen to be seeing, it in theory should help that provider more readily and more accurately access and help develop a treatment plan that's going to satisfy you as the patient and is going to help cure your malady or ailment that you've come in to see them about. You've got administrative data. You've got billing information on the providers. You've got billing information on the provider's practice. You've got insurance information. You go check into the doctor's office or the emergency room or the hospital. One of the first two things you've got to do is whip out your driver's license and whip out that insurance card, because they want to make sure they have captured that insurance information accurately. Otherwise, they may not be able to submit what did we talk about on the payer side? They won't be able to submit a clean claim. Remember, you have to have a clean claim submitted, or it's not going to start going through the adjudication process and to ensure that the providers get paid. They've also got provider information in that system. Primary specialty, secondary specialty. My provider that I had when I lived in San Diego was, his primary specialty was internal medicine. He had a secondary specialty, he was cardiologist. He also had a third specialty or a third or second subspecialty. He specialized in geriatric patients. He was head of internal medicine at UCSD, and I was by far, this was years ago, I was by far the youngest patient he had, but I happened to know him and I happened to like going to him, and he did a good job, and he continued to see me as a patient. But there is a wealth of provider information stored in that, where they went to school, where they got their residency, where they did their internship. On the administrative side, they also have the appointment information. They're going to look at the percentage of patients with appointments that don't show up. Look at the cancellation percentage. They're going to look at how many appointments a given provider or how many patients a given provider can see per hour. Let's say a provider can see 4 patients an hour. 4 patients typically in a 7-hour day, maybe an 8-hour day, depending on how the office is set up. Then you're going to see either 28 or 32 patients a day. If you're set up and you've got a really slick office system and you can flow the patients through, you may see 5 an hour. 5 times 735, 5 times 840. You know, there's a big difference in reimbursement, in total reimbursement or total payout between seeing 28 and 32 patients and seeing 35 and 40 patients a day. So on the provider side of the house, you're going to have just a wealth of administrative data. You're going to have financial data. Think about the office practice where I go see my primary care doc. They have a budget. They are budgeting. Remember, it's going back to your profit function. Profit equals revenue minus cost. So they've got a budget that they're managing to. They've also, got revenue information in there. They've got provider, they've got payer contractual information in there because they have to have that financial data, that contractual information. Remember, go back to the HCFA 1500 we talked about, and there was a column in there, one of those columns of information talked about bill charges, talked about what the potential paid amount was going to be from the provider. So they got the bill charges off the charge master. They got that potential allowed amount from the provider contract. They have that information stored in that financial repository. They've got just general expenses, general operational expenses, SG&A, just about everything that you would expect to find on a balance sheet or an income statement that you learned when you were taking your accounting classes. You've got operational data. You've got resource allocation. How is that not only, and it's just not the provider offices, but it's the hospitals, it's the ambulatory surgery suites, it's the urgent care facilities. They are trying to allocate resources in the most efficient manner possible. And it's going to have resource allocation information in that warehouse, in that system somewhere that they can have access to. They're going to have staffing information. They're going to have scheduling. They're going to have who's on vacation, who's working the shift, who's on, if you're on the hospital, it's, there's 3 shifts on the hospital, who's working shifts on a particular day. They're going to be trying to manage patient flow, not only patient flow as you come into the doctor's office, but patient flow as it exists in the emergency room, patient flow as it exists as you come in. If you need to be admitted to the hospital, you're going to have to go to the admitting office, or you're going to have to sit down and talk to somebody out in the main area that are going to walk you through the admitting process, get you admitted to the hospital, get you a room so that you can hang out in while you're in the hospital. You've also, on the information warehouse on the provider side, there is a tremendous amount, probably more so on the provider side when it comes to research and public health data, especially talking about disease patterns. And if you're a hospital or if you're a provider group that's involved in clinical trials, all of that information is going to be stored within that system that's feeding this information warehouse. You've got equity distributions when it comes to looking at lines of business. How many of your patients are commercial? How many of them are Medicaid or Medicare or TRICARE or VA? You're going to be looking at population health. How many of your patients, have diabetes? How many have congestive heart failure? How many, other episodes of care in the population health field that not only are you trying to manage, but you're providing information on those episodes of care within that population health continuum to the public health agencies. Think about evidence-based medicine. Information that's captured within, say, that EPIC system, or information that's captured within those systems, within either the provider's offices or in that hospital, is going to be utilized to do research and to improve the efficacy of treatment plans, to improve the efficacy of treatment protocols and disease cohorts. And it's going to drive the efficient allocation of healthcare goods and services through evidence-based medicine and evidence-based protocol. And with that, we're going to stop for a few minutes and let me think. I'm going to come back in a few minutes and we're going to talk about some of the things that providers actually extract information out of a healthcare data warehouse as they use not only on a daily basis, but they use through their analytical work and through the reporting process. Talk to everybody in a few minutes.